and I'm happy to introduce to you Marianne Alarie. Is that how you pronounce it? Or Marianne Alarie? She has gained her bachelor's degree in life sciences from the Queen's University in Kingston, Ontario, Canada. And then she went on to perfusion, get a perfusion degree from the Michener Institute of Technology in Ontario, Canada. Marianne has developed interest in education and research, and she became Kingston's Health Sciences Center student clinical coordinator. And she obtained a certification with simulation in Canada in simulation education. And Marianne, sorry, will talk to us about CytoSorb hemoadsorption. Thank you.
Hi, everybody. As he mentioned, my name is Marianne, and I'm a perfusionist at Kingston General Hospital, which is in Kingston, Ontario, Canada. Thank you. And today I'll just be talking on the case report that our team published back in 2022 on the use of CytoSorb hemoadsorption therapy during prolonged cardiopulmonary bypass in a complex cardiac surgery patient, as well as our center's experience so far using the CytoSorb. So just quickly, as I mentioned, I work for Kingston General Hospital. We're part of Kingston Health Sciences Center, and we serve the southeastern region of the province of Ontario, which is in Canada. We're a complex, acute, and specialty care referral center for a number of key needs, including naturally cardiac. We're a pretty small cardiac team. We do somewhere around 600 cardiac cases a year, and we're a team of 4 full-time perfusionists, and at the moment, 3 surgeons. We also naturally offer other perfusion-related services like ECMO and cell salvage, balloon pumps, and stuff like that. So I have no disclosures to make, and here's a quick look at what we will be talking about today. So first we'll go through what is hemoadsorption therapy and what is the CytoSorb for those of you who may not be as familiar with it. We'll go through some indications and contraindications, as well as the evidence, specifically looking at the removal of inflammatory cytokines from the blood during cardiac surgery using the CytoSorb. Then naturally we'll go through the case report, our patient, some perfusion considerations, and what we were able to conclude from that, and we'll finish on just discussing our center's experience so far and the protocols we developed. So as we're all very familiar with, the use of cardiopulmonary bypass during cardiac surgery is associated with the activation of systemic inflammatory response system. Surgical trauma, ischemia, and the contact of blood with artificial surfaces will all lead to the release of a number of inflammatory parameters like IL-6, IL-8, TNF-alpha, reactive oxygen species, complement activation products, and taken all together, they can lead to a number of postoperative complications like hypotension, bleeding, myocardial dysfunction, and eventually could lead to multi-organ dysfunction. So clearly there's still a need that exists to find ways to mitigate the adverse effects that result from the activation of the inflammatory response system during cardiac surgery. And that's where CytoSorb comes in. So CytoSorb is a medical device that can be integrated into a number of extracorporeal circuits, including bypass, but also ECMO and hemodialysis. And it's essentially a filter that's made up of porous sorbent technology, so a bunch of little pores that are made up of polystyrene divinylbenzene, and essentially it uses a combination of hydrophobic forces and size exclusion to remove substances from the blood. The filter itself is 300 milliliters in size, with 150 mils of that being blood, and the remainder of the volumes is made up by the beads. And it has a surface area of 45,000 meters squared, which is roughly the size of 4 football fields. It can remove substances that range from about 5 kilodaltons to 60 kilodaltons in size. And we can see here are inflammatory cytokines like IL-6 and IL-8 and the TNF-alpha. It's known to remove also myoglobin and bilirubin. We can see the complement activation products, and it can also remove a number of pathogen-associated molecular patterns. And as of late, it's gained a lot of interest for its ability to remove 2 of the leading antithrombotic drugs in the country in ticagrelor and rivaroxaban, and we'll touch on that a little bit as we go through the presentation. So indications for its use include sepsis, vasoplegia, endocarditis, leukocytosis, procedures with a high risk of complications or activating the inflammatory system, patients with significant comorbidities, specifically liver and renal dysfunction, long bypass runs of greater than 2 hours, and for the removal of ticagrelor and rivaroxaban in the last 4 to 5 days. Contraindications also include patients with low platelet counts, sickle cell crisis, those who've had immunosuppressive therapy, and patients who may be pregnant. So in terms of the research specifically looking at, again, removing inflammatory cytokines from the blood during cardiac surgery, it's quite scarce and has been inconsistent. A lot of the studies are small, but they've all shown that integrating the CytoSorb is safe and feasible, and there's been no device-related complications reported. So we'll go through a couple of those, and the first one being by Bernardi in 2016. And they looked at 37 patients in a single-blinded, randomized, single-center pilot study who were undergoing elective cardiac surgery, so cabbages, valves, and combined procedures where they anticipated a length of bypass of greater than 2 hours. And they looked at pro-inflammatory cytokines at various time points over the first 5 postoperative days, as well as the vasopressor requirements, fluid requirements, and length of stay in the ICU. And they found that using the CytoSorb was not associated with a significant decrease in pro-inflammatory cytokines, nor was it associated with any significant changes in the patient's postoperative course. They did find that IL-10, which is an anti-inflammatory cytokine, had a longer lasting effect, which they thought was worth noting and perhaps investigating further. Similarly, in 2019, Poli looked at 30 patients in a blinded randomized controlled pilot study, again looking at patients who were undergoing cardiac surgery at risk of complications. Some of their inclusion criteria were patients older than 75, long complex procedures, long bypass runs, kidney dysfunction, and they looked at quite a wide variety of inflammatory cytokines and also fluid requirements, vasopressor requirements, and length of stay in the ICU. They also did not find that using the CytoSorb was associated with significant decrease in pro-inflammatory cytokines or any significant decreases in vasopressor requirements and inotropic use. There was no significant improvements in acute kidney injury. And they also took the time to assess whether using the CytoSorb was associated with any alterations in the coagulation system. And they found that there was no alterations in coagulation factors or thrombocyte levels. Conversely, in 2019, Garreau looked at 40 patients in a randomized single-center trial, again, looking at elective cardiac surgery, so patients who are undergoing cabbages or valve procedures with anticipated lengths of bypass of greater than 2 hours. They specifically looked at IL-6, IL-8, and TNF-alpha, and they also looked at, again, fluid requirements, vasopressor requirements. They did not find that CytoSorb was associated with significant decrease in IL-6, but that it was associated with significant decrease in IL-8 and TNF-alpha. They also found that they needed slightly less vasopressor requirements, but it was not statistically significant. Some of the possible reasons they suggested as to why their outcomes were different than Bernardi is that their flow through the CytoSorb was 300 mils per minute versus Bernardi's 200 mils per minute, so they hypothesized that that might have had an impact, and also perhaps their selection of patients might have been sicker. And then finally, in 2023, Heyman did a systematic analysis or systematic review and a meta-analysis of 17 different randomized controlled trials, looking at 855 patients. And they found that the CytoSorb was not consistently associated with decreases in IL-6 or C-reactive protein or any other inflammatory parameters. And they also suggested that it might actually be associated with an increase in mortality at 30 days, although I've come across the opposite statement in other studies. So clearly there's a need to do more research to determine whether if integrating the CytoSorb during cardiac surgery is actually effective. Some of the possible reasons as to why these results have been inconsistent is, first of all, the length of time spent on bypass. You're typically not on bypass for very long periods of time, and even the longer bypass runs may not be enough time for the CytoSorb to actually remove the inflammatory cytokines. There have been studies done in patients who have received it postoperatively for multiple days, where they actually change out the filter for every 12 to 24 hours, and there have been more significant reductions of vasopressor requirements, so that might be one of the reasons. And in addition, the selection of patients. So this might not be something you throw into just any elective cardiac case. You might want to choose patients that might be a bit sicker, already present with a higher inflammatory load, like those patients with infective endocarditis or sepsis or undergoing transplants, and it might be more effective in those types of patients. So that being said, CytoSorb has been used in the European Union since 2012 and has been used in well over hundreds of thousands of patients that are critically ill, including ARDS, liver failure, infections, and et cetera, in cardiac surgery. And in 2020, the FDA granted it an emergency use authorization for COVID-19 patients over the age of 18. And later that year, also granted it a breakthrough designation for the removal of ticagrelor. And Health Canada followed their lead in 2021, also granted a medical device authorization for COVID-19 patients. And so given the fact that it had been used in Europe for quite some time in cardiac surgery, and there's some research, our center advocated for its off-label use during cardiac surgery, and that's what led to our case report, which we'll go through now. So our patient was a 61-year-old male who presented with severe mitral regurgitation, moderate mitral stenosis, moderate aortic stenosis, moderate tricuspid regurgitation, some coronary artery disease, and some mild left and right ventricular dysfunction with an ejection fraction of 46%. He had significant comorbidities, including end-stage renal disease that required hemodialysis, so an elevated creatinine and a low GFR. He had autoimmune cytopenia with severe thrombocytopenia of a platelet count of 74 pre-op. He was edemic with a low hemoglobin and a hematocrit of 29. He had heart failure, hypertension, COPD, a previous Graves' disease diagnosis, as well as atrial fibrillation. So it was decided he would need a mitral valve replacement, aortic valve replacement, tricuspid valve repair, single bypass, and a left atrial appendage clip. Given the complexity of the surgery and the anticipated length of bypass and this patient's significant comorbidities, including the renal dysfunction, it was decided that we would integrate the CytoSorb into our circuit in this patient. So in terms of setting up and priming the CytoSorb, it's not overly complicated and somewhat resembles a hemoconcentrator in a way. The company recommends using a gravity prime method where you take 2 liters of normal saline and let that passively flow through the column into a waste bag, making sure there's no air that goes through the beads, as that can deactivate the beads. But they also provide the other diagram where you would just integrate it into your circuit and prime it, kind of as you would a hemoconcentrator, and return it back into your reservoir. The recommended blood flow rates are somewhere between 150 to 700 mils per minute. We use a centrifugal cone and just passively had flow through the CytoSorb, although many centers also use a roller pump to accurately control how much flow goes through it. And as I mentioned previously, the volume of blood present in it at one time is 150 mils, but it does create a significant shunt in your circuit of like somewhere around 10 to 15% of your cardiac output. So that was the CytoSorb for this particular patient in our circuit. So we had it coming off of a high flow stopcock, off our recirculation line, post-oxygenator, and then return to the reservoir. Many centers also have it post-pump, but pre-oxygenator, returning to the reservoir. So that's also an option. So in terms of the procedure, preoperatively, our patient was on 2 mics per minute of norepinephrine. We initiated the flow through the CytoSorb as soon as we went on bypass, and we had flow going through it throughout the duration of the procedure. We didn't have a flow probe, but we estimated using our shunts, our flow was somewhere between 200 to 230 mils per minute. Roughly 10 minutes into the bypass run, our epinephrine increased to 5 mics per minute, and then that's about the time we arrested the heart at antegrade and retrograde microplegia using the Quest MPS 3. We were still on 5 mics per minute of norepi 30 minutes into the bypass run, and then 10 minutes after that, our pressures improved, so we went back down to 2. And then within an hour, we had MAPs of over 70, and we actually stopped the norepinephrine, and we didn't actually need any further vasoactive support for the remainder of the procedure other than the occasional bolus of phenylephrine. Of note, we also did zero balance ultrafiltration throughout the procedure using 2 liters of Prismasol 0, as well as removing about 5 liters of fluid. In preparation for weaning, we started dobutamine at 7.5 mics per kilo per minute and epinephrine at 5 mics per minute. As I mentioned, we had flow going through the CytoSorb up until the very end, and any leftover blood from the circuit and the CytoSorb was processed in a cell saver and returned later as there was some concern about right ventricular overload. Our total bypass time was 154 minutes, cross-climb time of 115, and leaving the operating room, we were on 5 of dobutamine, 6 of norepi, 5 of epinephrine, and 0.4 of vasopressin. We did do all of our coagulation testing prior to leaving the OR, and so we ended up transfusing 2 units of platelets and 1 unit of prothrombin complex concentrate in our patient, and throughout the entire procedure, the patient received 3 units of red cells. So this table summarizes a bit about what we just went through. So we can see the 2 mics per minute of norepinephrine pre-bypass. We stopped it within an hour. Leaving the OR, we on 6 of norepi, 5 of epi, 0.04 vasopressin, and 5 of dobutamine. We were able to stop the dobutamine within 1 hour post-op, and then within 6 hours, we were able to stop the vasopressin. So by 24 hours, we were on 2 of norepi and 4 of epinephrine. And the norepinephrine was stopped within the 24 hours. So by the end of the second postoperative day, the patient was on no vasoactive support. The creatinine and GFR did slightly improve post-op, which is slightly attributed to the Z-buffing that we did. We can see the hemoglobin and the platelet count also dropped post-operatively, and so throughout the patient's post-operative course, they needed another 3 units of red cells, 2 units of plasma, and 1 unit of platelets. Our lactates peaked at around 3.4 around 6 hours post-op, but they quickly normalized after that. Our total chest tube drainage was around 1 liter. We extubated the patient within 2 days, and the patient was transferred to the ward on the 6th day and discharged on the 11th day. So obviously we didn't measure the concentration of inflammatory cytokines in the blood, so we can't really speak to whether or not the CytoSorb did or did not remove inflammatory cytokines. But what we can say is integrating it into our circuit was safe and feasible, and it may have potentially contributed to improved postoperative outcomes in our patient. And we had no device-related complications. So, given the complexity of the surgery, the length of time we were on bypass, we anticipated significantly more vasoplegia in our patient, and so it was felt by the team that perhaps the outcomes were more positive than they would have been otherwise. So that was their very first use of the CytoSorb, which was back in 2021. And we've since then used it quite a few times, so that's led us to develop a protocol at our center where essentially just outline the indications, contraindications, and how to set it up, et cetera. But we really mostly focused our attention on using it in patients who have received ticagrelor in the last 3 to 5 days, primarily the last 3 days, as there seems to be more evidence supporting its use with that. And it's also not the cheapest product, so we try to focus our attention on the ticagrelor patients. The company also provides this table, which outlines a number of drugs that the CytoSorb does remove on pump as well, which is important to keep in mind. We have this printed out with our anesthesia team so that anytime we use it, they can refer to it, just be aware that some things may be altered. Something we've noticed is that our patients tend to move much more frequently when we use the CytoSorb compared to those that we don't. And so we actually redose rocuronium 2 to 3 times more than we would in other patients. The company claims that rocuronium is not removed by the filter, and so if that's the case, then there's obviously some interactions or other anesthetic drugs that are being removed, and so the patient's anesthetic requirements might be a bit more elevated in those patients that you use CytoSorb in. So since 2021, we've used the CytoSorb in 113 patients, with 73 of those patients being ticagrelor patients who have received ticagrelor in the last 3 to 5 days, primarily the last 3 days. But we have also used it in a few other patients, and for those other patients, we focus mostly on infective endocarditis, again, because there's a bit more evidence with that. But we have also used it in circ arrest cases, redos, kidney dysfunction type deals. And it's now become our standard of practice for patients who receive ticagrelor in the last 3 to 5 days to integrate it into our circuit. It's either requested by surgery or anesthesia, and usually know about it ahead of time, and it doesn't take too much time to throw it in. And we've had other good positive feedback from our team. They felt that perhaps our patients did better than expected, and that may have been because the CytoSorb was in the circuit. And in terms of the workload for the perfusion, it's not a crazy added workload, not too hard to throw into your circuit, doesn't take that much time. So it could be something that you guys might want to have on your shelf as a good therapeutic option for a certain select few patients. And that's all I have for you guys. I hope that was interesting, and I hope it's taking any questions. Thanks.
Thank you so much. It was an excellent presentation. Are there any questions from the audience?
I just have a comment.
Okay.
Thank you for reminding me about some history. I graduated from the Missioner 30 years ago.
Oh, did you?
And my first clinical rotation was at Kingston General Hospital.
Oh, nice.
So say hi to Maggie and Caroline for me. And excellent work. Thank you.
Oh, thank you.
Yeah. Yes. Of course, everybody wants to know how much it costs.
Yeah, so last that I heard, the filter itself is $1,500 US, so it's not cheap. I think that will likely go up. The company just completed the STAR-T trial, which was looking at specifically the removal of ticagrelor in North American centers. They rebranded it as DrugSorb in their study, but it's essentially the exact same product. So we expect that the DrugSorb, once it gets approval, might be a bit more than $1,500, but for the moment, CytoSorb is $1,500 US. They just came out with some preliminary results of their study. So I think they're hoping to get like FDA approval. Oh, I'm not sure. I think it's like we were getting it actually from Europe for quite some time, so it's not like, you know, it took a couple weeks. But then we had a distributor within Canada, and that was not far, so we were able to get access to it quite quickly. Yeah.
I have a few questions,
Okay.
but I'll start with the first. I may have missed it in the beginning because you're a really fast talker.
Oh, sorry.
But the contraindications, like
Yes.
Platelets less than 20,000 and pregnant or possibly pregnant women, why is that?
I think the concern about the platelets is, I'm not sure, perhaps like bleeding complications. We weren't too concerned about it because we were expecting we were going to have transfused platelets anyways in this patient. But that's what's listed, you know, by the company. Good question though.
And pregnant patients, is it like?
I'm not sure.
Okay. No problem. If anybody knows in the audience. So in practice, so you have a list of indications that you can use it. Do you still have to like, hey, is it okay if I use it, or do you just like, I need this, so I grab it?
We usually, so like I said, we focused our attention on ticagrelor, so we usually know if our patient's been on ticagrelor in the last 3 days. So we'll have a discussion. Like, we're a small team, so we'll never throw it in independently. We'll have a discussion with surgery and anesthesia. Or if we feel like, you know, maybe, oh, this patient's going to be a really long bypass run, really complicated, what do you think about us throwing it into the circuit? And then if it's a yes or no, then we go from there. But yeah, we'll never just decide to throw it in. We'll have a discussion ahead of time.
And what was I going to ask? Sorry. Yeah, you mentioned heparin is not removed.
No.
But in your great experience, do you see any that you need more heparin because it removes other things, or it's more?
No, we haven't noticed anything like that.
No activity.
No.
Okay. I'm out of questions. Any other questions from the online audience, or? No. Okay.
Thank you.
Thank you so much.